Welcome to the Prosthetics and Orthotics podcast with Brent Wright and Joris Peels. Hello, everyone. My name is Joris Peels, and this is another episode of the Prosthetics and Orthotics podcast. And with me is, of course, Brent Wright. Hi, Brent.
Hey, Joris. Good to be here again with you. Looking forward to another episode.
Okay. So first off, if you're new to us, listening for the first time, essentially, Brent Wright is an orthotist and prosthetist who is helping people with the digital transition, helping people go from something that uses, subtractive machining maybe, and a lot of work by hand, and helping them go digital with scanning, with software, with more CAD, and also with 3D printing and stuff like that. And I'm a 3D printing consultant. And essentially, we're both very curious about what this whole, additive manufacturing revolution or the digitization revolution will mean for orthotics and prosthetics. Is it going to change everything for patients, or is it going to change absolutely nothing? Or are some people going to use it as a niche thing? And that's what we're doing here with the podcast. And we're both basically curious. And so, Brent, who have you found for us today? Brent's the one that finds all the guests. So who did you find today?
Hey, Joris. Yeah, I'm really excited to have Ashlie White on with us. She'll have to dive into a little bit of her role, but I have known Ashlie for a long time. I would almost say we've matured in the field together. Essentially, we're roughly about the same age, worked the same companies, and have just stayed in touch. And so I'm excited to have Ashlie on. It's going to be a little bit different on this one, but I'm going to be curious to kind of get her feedback around kind of the business policy and such, potentially around 3D printing. But I also just want her to share her story around how she is helping better patient outcomes, as well as just awareness around our field in general. So, Ashlie, thanks so much for being on, and I'm excited to kind of dive into your journey in the orthotic and prosthetic field.
Brent and Joris, thank you so much for having me on. I'm so excited to join. I am the Director of Health Policy and Strategic Alliances at the American Orthotic and Prosthetic Association. And as Brent said, my primary role now is in helping advance health policies that increase patients' access to orthotic and prosthetic care. But the journey to get to where I am today has been a lifelong one. As Brent said, we basically came up through the profession together, him as a clinician and me mainly on the administrative side, working at some of the same companies and have had the opportunity to know each other for a really long time. But I grew up in the profession. My father is a prosthetist, and I've never known a world without patients that needed the services of an orthotist and prosthetist, or the challenges that they face trying to get access to those, to that care and those devices. And so I have a passion for this profession, but also recognize that some of these issues, some of these challenges that face the profession have been around for a very long time. And so we've got to think strategically. We've got to be future facing when we think about what the solutions are going to be. And so I think that's why it's so interesting to chat with you two today about 3D printing and the digitization of O&P processes.
Okay. Well, I think it's interesting that you saw your father do it, and then you go into the same field. I mean, that gives you a really long perspective. What do you say the biggest things are that changed? And if we're looking at that in the last years, so what's the biggest thing from let's say your father, what you remember from him, and what you see now in a kind of a modern day practice?
That's a loaded question. On the policy side, I could go for hours. What I'll say just on at face value, there are some, I think, pretty big differences. I think O&P is still at the intersection of art and science in a way that makes it unique. And I think there's a beauty to that. And I don't think that that has to mean plaster. But I think that the qualities of the day-to-day work remain largely the same if we're able to capture, if our businesses are able to capture those moments, those unique moments where they see a patient come in, maybe in a wheelchair into their facility, and watch them walk out, right? So there is incredible benefit to being a prosthetist or orthotist that remain central to this profession. But there have been so many transitions. I mean, materials alone have an entire, spectrum of change over the years. The first socket my father made was made out of wood. I'm sure Brent has heard that story. And so, we're talking a really drastic change in something as simple as a material, which isn't simple at all. And so I feel confident that if you look at progress so far, that the expectation should be that we are only heading further in that direction. There's no end point to this transformation. It hasn't been one so far.
Okay. But I'm actually very, very interested in this policy thing, because I think, from what I know nothing, right? But I think it's really kind of like this whole sector is a bit weird, because there's a doctor and there's a patient, and then all of a sudden, by some magical means, the patient shows up in the O&P office. And then that person, the O&P practitioner, can then get reimbursed one-time amount, right, for something that actually going to take them a lot of meetings and a lot of follow-up, right? I mean, that's at least what Brent explained to me. I mean, so explain this policy thing. What has changed in terms of the policies then over these decades then? Because that I think is really interesting, because it is a bit weird, I think, from somebody outside the profession. It works very differently than other medical things do, with insurance and with the government and stuff like that, right?
Yeah, the reimbursement scheme is quite different than other healthcare spaces. It isn't entirely unique in terms of what you see happening with ACOs and bundled payment and fee for value. Actually, we were a bundled payment before bundled payment became like a cool thing to do with insurance companies and accountable care organizations. We have always been an all encompassing care protocol for an episode, and so that episodic care that we provide and up until the delivery and then 90 days after delivery, that's all reimbursed through a global payment, right? And that has always been the case. This profession primarily has been founded on the device as the benefit. The actual device is what insurance companies believe themselves to be paying for, which is where the rub enters, right? So we have this dynamic where on paper, the benefit looks like a device, but what's actually being provided to patients is a series of care that otherwise the patients wouldn't be able to utilize that device if they didn't receive. And so there's a mismatch between what a insurance company views as your responsibility as a clinician to provide their patient and what is actually happening in practice. And so that's the challenge. If you go back 20 years or more, you would have seen a dynamic in which the recognition of the specialty of prosthetic and orthotic intervention was less scrutinized because payment systems were structured differently. So healthcare is a big business in America. And when you look at what that means, primarily that means that insurance companies make a lot of money. And so they are incentivized to figure out ways to make more money while holding up the values of their organizations and providing their customers that product being their insurance coverage. Now, public payers have a whole other set of challenges, primarily around needing to protect a trust fund that is being paid into so that patients can receive what they need that are beneficiaries of those programs. That includes Medicare, Medicaid, and the VA. And so the dynamics have shifted a little differently in both of those scenarios. We have different policy problems with private insurers than we have with public insurers, with public payers, but those problems still exist. And a lot of those are in recognition of the challenging environment associated with healthcare cost.
Okay. So what does that mean for like me as let's say let's talk about first, like from the practitioner from the practitioner's point of view, what are the challenges? What is the major thing like that's really kind of like really difficult for somebody like Brent or somebody like a regular practitioner? What would be the big problems then?
I wish that it wasn't such
too
a
big
headache.
a question.
I every day at my job, in my role at AOPA, I hear about a different challenge facing our clinicians every day. And those challenges are wide ranging. It can be as something like, I'll give a few examples. In Colorado Medicaid issued a 45% reimbursement reduction, just across the board, with no methodology released, no inclination, like any kind of explanation. Just cut the reimbursement rate for cranial remolding orthoses. And when we challenged them, we asked for the methodology used to come to this number. They immediately reversed it. Immediately. And they reimbursed everybody that they had underpaid.
But that could be good. That could be a mistake. It could have been an honest mistake. I actually like that.
It was a poorly made decision because some consultant somewhere said, "Hey, we know where you can save money. Look how much these cranial remolding orthoses cost, and look how much you're paying for them." And they didn't take into consideration any of the care protocol or the follow-up visits or the actual oversight that the orthotist is providing when they deliver a cranial remolding orthoses. So they looked at cost of material, essentially, cost of the device and the delivery moment. And they said, look at all this money we can save. And they didn't take into consideration the care that was being provided. So that's why we have to continuously tell the story of the care being provided, because otherwise payers only see the device. And that's what this whole conundrum, a lot of our issues, a lot of our challenges stem from that. I think documentation requirements that fall on the prosthetist and orthotist but aren't the responsibility of the prosthetist and orthotist are absurd. So if you are expected to make sure that the doctor writes something in his note verbatim that's going to either allow your claim to go through or kick your claim out or create a denial, it puts a type of burden on a clinician that's not expected in any other sector of healthcare. Yes, documentation should corroborate that your patient has the condition that is being treated, but that should be the extent of the requirement on the physician's side, right? The physician is saying a patient needs this device for this reason. And in most cases, that should satisfy the criteria. But there's been a lot of red tape, a lot of provider burden that's associated with documentation over the years. And that's one of the biggest shifts, I think, that happened back in 2011 with the Dear Physicians letter that came out, where it described this sort of elaborate type of documentation that was required in order for prosthetists and orthotists to be able to bill for the devices that they were delivering. And it put people out of business, because it was a complete shift in the way that those businesses were being run. Now, I think there's a middle ground there. I think it is our responsibility to make sure that prosthetists and orthotists notes adequately describe the work they're doing, because they're healthcare clinicians, and all healthcare clinicians have to define the work they're doing. But to be responsible for what someone else puts in their notes is a little overburdensome, and it is a challenge for patients to get what they need.
Is it really? Is this only? Am I being too cynical here? Or is it just like, these insurance companies are huge, but the drug companies are also gigantic, right? And then there's also health systems and things like that that are big. Are you just like the smallest players in this game? Is that what's causing a lot of these problems? That you're just not as powerful as all these other guys? Is that it?
Our profession is one of the smallest healthcare professions in the nation. But our patient population is actually not. So I did some kind of digging, and I had a really interesting conversation with a physiatrist recently, a physical medicine and rehab doctor, who shared with me that in physiatry school, they have an opportunity to specialize in spinal injury. And there are 19,000 survivable severe spinal injuries every year, 19,000. And there are over 165,000 survivable amputations every year. And so if you really think about it, here's a specialty of a very small niche group of individuals with severe spinal injury that an entire physical medicine and rehab education system and has dedicated to a specialty in. And yet our population is nearly 10 times as much, our patient population. And that's just our limb loss and limb difference patient population, not all of the patient populations that are impacted by orthotic intervention. So I actually think our patient population is not that small, which is part of the reason that there's pressure on the systems, the payment systems. They see ways to save because there are more patients in our care than are in some other niche, more rare disease sectors. And rare diseases generally rehabilitative conditions tend to have harder time in getting paid in healthcare. This is a common story in other health sectors that are more niche and have more variety, like what we experience as our O&P clinicians experience.
Yours, I've got an example for you just on how like absurd sometimes this is. So I have a patient that I've been seeing for a very long time, pediatric patient, missing a limb from birth. And we actually, submitted the documentation, all that stuff. And it came back as the prosthesis was denied because now, granted, she has not changed insurances, none of that, because the doctor didn't say she was an amputee. But they've paid for multiple legs beforehand. So it's like, they have all this history of paying for a prosthesis, all this stuff, but and doctor's notes that have said in the past that she's an amputee, and obviously she's growing and that sort of thing. But because this specific event did not have it that said, hey, she's missing a leg, they just went ahead and denied the whole prosthesis. And it's like, this is a lifelong thing. And then, in fact, that's one of the things that you check, that being an amputee is for the rest of your life. And yet they just are so narrow focused, and they just try to squeeze you. So it's just an interesting field in that sense of trying to get this play of getting the doctor's notes, your notes, in an insurance company. You're really at their mercy, which is sometimes a very difficult place to be. And I hate to hear the stories like what Ashlie said. Like, people have literally gone out of business because of that.
It's super strange. And okay, another thing I'm really interested in now that I have you on is the numbers. So how big is the patient population then? And is it? And so you did kind of allude to a little bit. Tell us a little bit more about the numbers, because like you're probably better placed to do that than other people we've had on before.
I liked those physiatry numbers because they're from an academic setting, and so I will use that survivable amputations approximate number. But the studies that we actually have that give us the number of individuals that experience limb loss, have amputations every year, are quite dated. This is why the Limb Loss and Preservation Registry Project is so important. Population health data, understanding the population of patients, is something that we have not done very well as a profession. And part of that is because people lose their limbs for all different types of reasons. So a specialty that is taking care of dysvascular patients or diabetic patients, those vascular surgeons are experiencing amputation as a failure in many cases. Now, hopefully those trends are changing. We are definitely trying to get the message out that amputation is not a failure, that amputation can be a chosen procedure, and that we should give patients more information to make those decisions with their healthcare providers. But historically, those numbers they're not the goal, right? The goal is never to have to amputate someone. And so what we see is sort of these disparate studies that have different numbers noted. And the national study that was done is actually from 1986, projected out. It's a modeling that says, well, by this year, right, 2022, we can estimate that there are 200,000 amputations every year. But again, that is very dated data. And so the registry project is instrumental in making sure that we can get a handle on the actual numbers and some of the demographics that we're seeing. We know there are huge health disparities and inequities in this space that need to be addressed. And so again, having good data is going to be really important moving forward. So that was a little bit of a politician's answer, but it's a true one. It's actually one that I will dedicate future time to making sure that the registry thrives so that we can get this data. But also, if you think about the orthotic patient, again, we're talking about conditions that can impact an individual's ability to be mobile or to utilize their limbs. Those conditions can be anything. You can have a fever today and end up with a limb loss tomorrow. The reality is that because we impact so many different areas of the healthcare spectrum, we are a niche specialty, but we touch a lot of diagnoses as a profession. And so it's hard to have the numbers. We'd have to do some kind of correlation of, how many post-stroke patients actually receive an AFO. You'd have to look through like the stroke patients' records, right? And then you'd have to do that for every patient population you touch. And so some of the bigger companies have really good data they can look at, and they can say, well, we know how many of this type of patient we see, how many of this type of patient we deliver devices to. But our estimation is that is grossly underserved all around because O&P is such a small field. And so again, the numbers aren't there, that we don't have hard data to answer that question, but we're working on it. There are efforts underway to try to get a handle on our population data in a more precise way. And I have to give credit to some of the larger companies that are, really dedicating some financial support in this space, as well as to the registry for its efforts to try to help us get a hold of our population health data.
Because I think with a larger aging population, with diabetes and also more treatable some cancers and stuff, we would expect this actually to be growing, right? Or not? Or is it that, for example, workplace safety is so much better, so it actually is reducing? Or do you have any idea of that at all?
So the workers' comp reports don't show a decrease in amputations related to work environment events. So I would say that's a steady or growing population. We know the diabetic population continues to grow, so that the limb loss due to dysvascular issues is growing. We know that peripheral artery disease is at an all-time high, and that patients are regularly losing limbs because of that condition. And that disease is actually directly related to another area of inequity where individuals don't have intervention early enough in their healthcare experience to prevent them from losing a limb. And so we have an opportunity to intervene. Actually, we could be part of the solution as an orthotist providing care to a patient that's at risk of limb loss. We do have a role to play there as well. So I think we are seeing diseased populations grow at a rate that is making our field. We need to grow our field, right? We need to make sure that we're getting the pipeline of individuals interested in O&P. And I can promise you, we do have workforce shortages right around the corner, if not already facing this profession.
Okay. And do you think that also that, well, okay, so it's kind of, too small, as in revenue wise, if you will, and patient population, or perceived to be small as patient population, but if we don't know how much, then yeah. And also, like the companies in O&P are relatively small, right? The individual practitioner doesn't have a lot of power when compared to GSK or companies like that. And even what you say to those large companies in your industry are much smaller than these really large,
Absolutely.
these really large HMOs or whatever, these really large insurers. And is there a chance that you're, that's really hurting the industry because you don't know where to invest in? Because, for example, if you're talking to a materials company, they may not want to make a new material because they don't know if there's like how many patients are out there. They may not want to make a new machine because they don't know how big the industry is. Is that really hurting us?
I want to be careful how I answer this question. Good market research would show that this is a prime area for investment. So I don't think that investors are discouraged when they look at our space. I'll lead with that. I think that a materials scientist studying, so let's back that all the way up to the actual individual that's doing the research. They are more likely to find funding for their endeavors in other spaces than they are in O&P. And their career trajectory has a longer arch, has more viability if they're in biotech that is going to impact larger populations than if they are looking at making a specific type of device with a certain material, right? And so we do have some programs that are designed directly to impact that, to engage that. Just our pilot grant program through COPL awarded $240,000 in pilot grants last year to encourage new and young investigators to get involved in O&P research and to help projects get enough pilot data to mature to the level that they would then receive the NIH grants or the DoD grants or the VA grants. And so there are research dollars in all of those entities that are designated and restricted for orthotic and prosthetic research. So I think the possibilities are there, but all the pieces have to fall into place so that we can continue to grow our research field alongside our clinical field. So if a scientist is saying, where am I going to have the best career? Well, it depends on what their exposure has been. If they get involved in O&P, a lot of times they stay. But I know a couple of really bright materials scientists, engineers that have been part of projects with us that have gone on to change their specialty or change their focus in their studies, in their science. Brent knows a few of them. And so, we had them for a moment, we had these bright lights, and then they left because they found that they were going to have better opportunities elsewhere. That's always a risk, but it's a particular risk in our space if we can't find funding for the projects that these organizations are interested in developing. And the healthcare policy side of that doesn't help, right? Because if you can't get something reimbursed, then why are you going to study it? The ROI isn't always there.
Actually, I think it's interesting that you talk about, I'm super curious, and I know you kind of touched on it, Ashlie, but you talked a little bit about the attrition of our field. Not only do we have some people retiring, but, what are you seeing as far as, you mentioned workforce shortage, but then we also have this kind of ballooning potential patient population. So what are you seeing kind of boots on the ground and from a national level, or maybe even international, if you're tracking it that way, on this idea of a workforce shortage for orthotics and prosthetics? And then what are, I guess, some of the things like encouragement for people to get into the field?
I know that ABC has just invested a tremendous amount of resources into a recruitment and marketing campaign around the profession. I think that is will have an impact. I mean, it'll take some time to see the fruits of that labor, but I think it was absolutely needed, and it is the right. It's a wonderful gift that they're giving in a way to make sure that young people are exposed to the profession of O&P early on. So there's some changes that have to happen culturally to recognize that, this profession was made up of, my generation alone. I have friends that I've known most of my life that are in this profession that are second and third generation children of O&P. We exist. and that was the way you knew someone that did this work back in the day, or you were exposed to it in high school somehow through somebody you knew. Now we know that the world operates differently. Things are not, they're not so face to face. There's a lot of online activity, and we've got to rise to the occasion. We've got to meet people where they are and make sure that they know about us. And I commend ABC for the work that they're doing. AOPA has also launched a campaign, We Are O&P. It's a hashtag that, we tag on to anything that tells the story of how an orthotist or prosthetist engages with their patient. Making sure that the world knows that we should celebrate the successes of patients that have thrived, that have persevered and overcome the challenges that they faced. But we also have to recognize the interventions that occurred and who provided that care. And so that's what We Are O&P, the hashtag We Are O&P is all about. So there's these efforts underway to address it. In numbers, I think we're looking at a shortfall by 2025. So now we are in a shortfall for practitioners in the United States. I think that the workforce shortage has plagued the world, so at an international level, for a long time. We have been fortunate to have a workforce that accommodated the need up until now, but that is not the case for many of the other countries. Many of the other countries struggle to find the people that can provide this care. And so you'll see a lot of different models in other countries where they're using physios, they're using physical therapists, or using other types of clinicians just to make sure that the care is provided somehow. And so if we find ourselves in a situation where we are now at that, we have that gap, and that gap has to be filled, someone will fill it. And I really hope it's O&P clinicians.
And do you know how big the O&P clinician group is? Do you have any kind of idea on that, like in the States or worldwide, or do we have any idea how many of these people there are?
Well, we know ABC and BOC published data on the certified clinicians. So they are the credentialing agencies that certify orthotists and prosthetists in the United States. There are similar entities in other countries. So I serve on the ISPO Global Exchange Partnership, and those numbers are tracked by ISPO. But there are less than 6,000 accredited businesses that provide O&P care in the country.
And when you say, because I thought it was interesting, you said you hope it's O&P people filling out the gap. Because what do you think people do? They're just going to go buy things online, or going to what's the alternative then? Do you think people are like DIY their own stuff, or what's the thing?
Well, that happens now. All of those things happen right now. It's just that the gap is small enough in many cases that isn't a prevalent experience. But Brent knows I've seen patients walk in with something that they bought online and ask, can you help me with this? It's what happens is that they still need the care. They're just not going to get it. And that's the scary part. The orthotist and prosthetist provide a sometimes life-saving intervention for individuals that if you remove those individuals, the patient's not going to have access to the same level of expertise for their journey following that the device intervention. And so my biggest concern is that patients won't have the outcomes that they deserve or that they are paying for in any other environment. Orthotists and prosthetists really are the most appropriate individuals to be providing this care at this point. But again, if a huge gap is created and someone has to fill that gap, then you'll start to see scope of practice challenges. You'll start to see encroachment from other specialty areas, because they're like, well, somebody's got to take care of my patients. You're not doing it. A great example of this is in diabetic shoe care. So many companies have struggled to provide diabetic footwear to patients. So patients who have diabetes are at risk of losing their limbs. There's prevention model that shows that if you have certain types of intervention, not just the shoes, but other types of intervention, that you can prevent the need for amputation, or you can hold off the need for amputation and whatnot. You can heal wounds. All of those things are real. And I think that it's become kind of one of those scenarios where businesses operate at a loss occasionally in order to be able to make sure that they have these patients in their sphere because they might lose their leg one day, right? Like, that is not the profit and loss game that gets played in O&P is not healthy, but it has served the patient so far. We're just at a turning point that it might not work in the future. We have to be paid for what we do, period. And so if you're providing a life-saving intervention or a limb-saving intervention for an individual, that is what you should be paid for, not whether or not the shoe costs X and here's your reimbursement plus whatever, right? Like that model doesn't work for that healthcare intervention. And that you can replicate that in other scenarios. Some of the most time-consuming and intense work that orthotists do are in operating rooms or post-operative rooms. And sometimes those interventions reimburse the least. And so there's a lot of those kinds of scenarios and dynamics at play.
Okay. So, and I think, I think it's interesting to look at this. Well, picture to me, let's say I'm like a high school student, right? I mean, for me, the work seems really, really gratifying, right? So imagine I'm a high school student. I don't know what to do with my life. Why should I do this? I mean, because I think the work looks interesting, right? I mean, we're helping people walk, right? Or walk without pain or with less pain or something like that, or helping them, go to work again or something. So it seems like that would be really rewarding. And actually also just like making stuff all day that hey, I'm interested, right? But pitch it to me, because like, is this a good thing financially as well? Is this a good thing? Like, is this nice to do this for 20 years, or you know what I mean? Like why would I do this? Why would I go in this field?
Yeah. So that's actually one of the more positive points for this profession. Right now, the studies that we do on salary, AOPA does a compensation report every other year, and those studies align O&P at a middle range career with any other allied health profession of similar style. So the therapy groups, middle of your career, you're making as much as a physical therapist. You actually have you have more growth opportunity on the financial scale than PTs do if you're a CPO. So you can make more money than a physical therapist or an occupational therapist as a certified prosthetist orthotist than your allied healthcare partners can. So it's still a financially viable profession to go into. Absolutely.
And do you think like and what do you think is going to change? We haven't. I think it's really fascinating what we touched up so far. I think that's great. But this digitization thing, is this going to be what saves everyone because it makes everything better, or is it going to be just a small trend? How do you think? How impactful is this going to be?
I think progress is important. The recognition of what a new manufacturing process, a new workflow process, a new way to engage a patient protocol, a patient care protocol. I think all of those things are important to explore and to optimize and to invest in. I feel like the idea of 3D printing as like is this going to change the face of O&P? I think if you think that, then you're thinking about the thing and not the patients. And so I like what I'm seeing. I like this exploration of a new frontier in all aspects, right? We're not just talking about the materials or the manufacturing process. We're talking about workflow organization, different ways to approach central fabrication, different ways to provide devices in a different time frame. I mean, think about, I happen to know a lot of the work that Brent's done over the years. And I am so, I'm in awe of the service that Brent has dedicated himself to for many of our challenged areas in the world that need orthotic and prosthetic intervention and don't have access to facilities or devices or care. And so in ways that we can help patients, then we should be doing it as much as possible, recognizing that there are standards, and I say standards loosely, not officially, so ISO don't get mad at me. There are quality requirements, right, that we still have to care about in a healthcare environment. And it's actually, as a favored nation is what, they put us into this category in America. We have a responsibility to make sure that we uphold a standard of safety for patients, so that when we say, we're a little worried about the vulnerability at this point of a device because of this material or the way this material is constructed, it's incumbent upon us to study that, to feel confident that we're putting patients on safe devices and safe materials, and to continue to improve, right? So as long as this is an improvement process, as long as this is an exploratory and scientific and academic endeavor alongside of all of the other aspects of user interface and care provision that's happening right now through mechanisms like 3D printed devices, that I feel like there's a really healthy way to approach all of this, and I'm hopeful that that's what we're doing. I'm excited about it. I think the profession is excited about it. So I don't know. That was a little rambly, and I apologize. I'm happy to redo that question.
No, I think that's a good point, though, Ashlie. Yeah, just what's interesting is I love the point that the device still has to be fit, right? It's not about whether it's 3D printed or not, and then we have to have standards, and both of those together means that there has to be some sort of clinician certified person that is in the middle of all of that. And so I think those are two important points. But I do love the idea of getting more data, right? And I think 3D printing lends itself to getting that data to make sure that it's safe, and it lends itself more to it than like traditional manufacturing processes. So it's a matter of how to get all that out, and then it's something that Joris and I talk about is how to. It's not even about the process; it's about making sure the design is the right thing for the patient, strong enough, and such. And so you can have a poorly designed something on a very expensive 3D printer, and it's still a poorly designed, going to break something. Whereas if you design it correctly, then you're off to the races. And that's where the data needs to revolve around. And that's where I think people get really excited about is this idea of design for prosthetic stuff and doing stuff that you can't necessarily do with traditional fabrication.
Okay. Thank you. Well, guys, I thought this was a really great episode. I really, really enjoyed this. I think it was a very different look from a very different way. Ashlie, thank you so much for being with us today.
Yours, thank you so much for having me, Brent. As always, thank you so much for the work you're doing, and I look forward to hopefully working with you both in the future.
All right.
Awesome.
And Brent, thanks for being here as well.
Oh, yeah, this was great. And
thank you for listening. This is another version of the Prosthetics and Orthotics podcast. And have a wonderful day.